Welcome everyone to our Buncke Clinic Virtual Visiting Professor Series. I am Bob Aksafa, and on behalf of myself and my partners at the Buncke Clinic, Drs. Greg Buncke, Rudy Buntic, Andrew Watt, and Walter Lin, I'd like to welcome you all to this afternoon's talk, or this morning, depending on where you are. We have the distinct pleasure and honor today to welcome a good friend of ours, Dr. Peter Su, from Asan Medical Center. Give us a talk today about lower extremity reconstruction, specifically propeller flaps. A little bit of background on Dr. Su, for those who have not met him yet. Dr. Su is an assistant professor of plastic and reconstructive surgery at the University of Ulsan College of Medicine and Asan Medical Center. He obtained his MD and PhD from the Graduate School of Ulsan University, followed by a microsurgery fellowship at Asan Medical Center with Professor J.P. Hong, who gave us a talk last month and will be giving us a second talk in July. For about 3 years, he was a breast surgeon at Iowa Medical's Women's University Hospital before moving on to Asan Medical Center. And currently, he's a specialist in a number of things, but specifically with lower extremities as well. But he also works on lymphedema as well as cancer reconstruction with sarcomas. Again, his major work has been recognized for both research and clinical work in wound healing, diabetic foot reconstruction, lower extremity reconstruction, sarcoma, and lymphedema surgery as well. And he's currently the program director for the residency in plastic surgery at Asan Medical Center. I had the pleasure of meeting Peter my first trip to Seoul when JP hosted me. And it was a fantastic time in meeting not only the residents, but also all the attendings, including Peter. And we actually had a good time at the Korean Society, which was just a couple of days after that. So this is a picture that some of you have seen here, and you've actually seen some of these folks give us talks already. So here's Hide Yoshimatsu over here. Here's Marco Innocenti, and here's JP, obviously. And this is where, during this trip that I met Peter, and it was actually a really fun time to meet new people and obviously talk about microsurgery and learn a lot of new things. And here you see Peter talking to Wei Chen, who is now at the Cleveland Clinic. The meeting itself was fantastic. This is the big grand dinner that we had. And again, you can see Peter here having dinner with Hide, and here's Marco Innocenti here as well. So really a fantastic time. And I think I encourage anyone who has the ability to travel to do so, because it's actually a great opportunity to meet people and also learn quite a bit, no matter where you are in your career. With that, Peter, thank you so much for being with us. It's really an honor and a pleasure to have you, and we're really looking forward to hearing your talk on propeller flaps today. I'm going to give you presenter controls in just a minute here, and you should be able to share your desktop with us. And down below on the screen, you'll see a screen button. If you push that, yeah. Perfect. And I'm going to ask everyone on the call to please mute your microphones and also turn your webcams off during the talk, and then we'll go with questions afterwards.
Can you see it? Can you see the image?
Yep, we can see it. It's perfect.
Thank you very much for introduction, Safa. It's my pleasure, great pleasure to speak as a virtual invited speaker here. I'm gonna briefly talk about the propeller flaps in lower extremity reconstruction, and it's not that difficult. It's really easy and simple and basic. So I think we want to share some of the basics and basic concepts of lower extremity reconstructions. So I have some bias. I'm a microsurgeon, and I'm working in a medium-sized hospital. It's Asan Medical Center. We have 8 more full-time faculty, and we do about 600 plus free flaps and 100 plus lymphedema surgeries. And we're working with 10 residents and 5 clinical fellows. And actually, I am the skip flap surgeon. I do most of the soft tissue reconstruction. I do skips. I think I do more than 80% of the cases. I choose skip to cover the defect. It's really good flap, as you heard from Hide, and that's my bias. And I'm gonna talk about the algorithms for the lower extremity soft tissue reconstructions, and also talk about the propeller flap indications and design. So propeller flap from the Tokyo Consensus in 2011. It's a propeller flap is an Allen flap that reaches the recipient side through an axial rotation as a propeller with 2 blades of the unequal lengths with the propeller forming the pivot, point. It's quite a common and well-known flap, but actually in no paper there's not described that well. So we have to do by yourself and figure out to minimize the partial necrosis and flap failure. So I'm gonna try to give some answer to some of the questions. Which propeller should we choose for the propeller, and whether there's a limitation of the flap size, and whether 90-degree rotation angle is better or the 180-degree rotation angle is better, and what can we do if there's ischemia after rotation of the propeller flap. So when we do we have to do the soft tissue reconstruction of the lower extremity, we have to think about many things. We have to think about defects. First, distance from the vessel to the defect, and width of the defect, and thickness and the dead space of the defect is really important. And also we have to consider the position of the patient during the surgery, because we don't want to change the position during the surgery. It adds some more additional surgical time, and sometimes it adds the increase the infection rate. So we don't want to change the position during the surgery. And also we have to think about the donor scar. So based on that considerations, we had the algorithm. If the patient is doing the surgery on spine position, width is larger than 10 centimeter, and we need a muscle or we need a thick flap, we did PAB. And if you need muscle, we did ALT. If the width is narrower than the 10 centimeter, and if you need a long pedicle, we did ALT. And if you need we don't need that long pedicle and the width is narrower than 10 centimeter, we use skip. In prone position, we choose those flaps, and lateral position, we could do ALT, TDAB, or skip flap. And for other indication, we use the propeller flap. But these days, it's slightly changed, because we can elevate large flap, we can elevate skip with long pedicle, we can add fascia and bone on the skip flap. So in most of the cases, we use skip flap for all the soft tissue reconstruction of the extremities and trunks. And propeller flap, the same, it has other indications. So if there's this kind of big, huge defect on the trunk, it's not possible to use the propeller flap, because there's not enough tissue around that defect. So we have to think about doing the free flap. And also skip is maybe not possible because it's too large. So for those defects, we use ALT 35 by 22 centimeter. So you can cover the defect without any flap necrosis or marginal descent. So for this 68 Kaposi sarcoma patient, after excision of the tumor, we need a really thin flap to cover the defect. Okay, doing the skin graft, but it'll take a longer time to heal, and maybe it's not durable for the friction of the shoe. So we elevate the ALT with in between the superficial fat. So we elevate, the flap thickness was 4 millimeter, and we cover the defect, and without any debroking surgeries, he can use usual shoe he used to wear before the surgery. So this kind of defect, it's not possible to cover the defect with propeller flap. Another defect, lower leg. After tumor excision, we need about 6 millimeter thickness flap. So we elevate the flap within the superficial fat layer, and we cover the defect with the thin ALT flap. So as you can see, just after, it was after 3 weeks, but as you can see, there's no swelling. The contour is really good. For this kind of defect, we don't use the propeller flap. It's much better to use the free flap to cover the defect. Unfortunately, she had a recurrence after 1 year, so we did another flap coverage also with the skip flap from the contralateral side. So this is after, during the radiation therapy, without any necrosis. The contour is quite good, so we can use free flap for those defects. Also for the trauma case, with a large lower leg defect, it had a bilateral defect, so we use skip for the right side and ALT, thin ALT for the left side. So we can cover the defect decently. 64 knee defect and had a capsule was excised, so we have to reconstruct the capsule. Also for this defect, it would be much easier to use a free flap to reconstruct the capsule and cover the soft tissue. So we use ALT with the tensor fascia lata, and this is during the radiation therapy, and this is after radiation therapy. Another knee defect. For these defects, we use skip flap with fascia, deep fascia here. So we reconstruct the capsule with the fascia and cover the skin with the flap. So for another ankle defect, it's quite difficult to use the perforator because it's not cosmetically good if you use the propeller near the ankle area. So we did skip flap to cover the defect. This is after radiation therapy. This is the flap here. So it's really, for the ankle defect, as we all know, the free flap is much better for many reasons. So posterior knee defects, popliteal defects, large defect, is quite difficult to use this, cover this defect with the propeller. So we elevate the skip flap. We did small amount of skin graft on the donor side. We can achieve this quite good result. Also for the large defect on the back, because this patient had a margin also after the burn. So we excised the tumor, and after that the defect was quite large. So we elevate skip flap on the lateral position, and we elevate 23 by 10.5 centimeter D flap and cover the defect without, there was no marginal necrosis, and we close the donor side primarily. This is after 2 months. Then when do we do the propeller flap? For the propeller flap, there should be a really good perforator near the defect, and the defect cannot be that big. The defect should, the longest diameter should less than 15 centimeter, and there should be abundant tissue and enough skin laxity near the defect, because we don't want to do the skin graft on the donor side because it's cosmetically not good. It's not the plastic surgeon should do. In those cases, we would prefer to do the free flap to cover the defect. Even though it takes more time, we prefer to do free flap for those kind of defect if the donor side cannot be closed primarily. So why propeller flap? Because many people think that easy. Our resident always said, "Oh, I think it's possible to do the cover the defect with propeller flap," because they want to go home early, because there's no micro, there's less pedicle dissection, and it's fast. Most of the free flap, it takes from 2 to 4 hours mostly, but if you do the propeller, sometimes you can finish within one hour. So it's fast if everything goes really good. But is it really easy? I think it's not that way. Many people might think that Mr. Bean is riding rubber every time, but actually he drove this Mercedes AMG with gullwing door. It's different. So if you see this kind of small defect with the plate exposure on the lower extremity, and you find really good perforator near those defects, you might think that you're going to elevate the propeller flap and advance it and close it. But in many cases, you might have this kind of a partial necrosis on the tip, and unfortunately, most of the cases there is implants on that area. So for those, we did this surgery on less than 30 minutes, but it ended up expending 1 week of more admission, and we did one more times a free flap to cover those defects. So this is after surgery. This might be simple, but it has more complications. There are many papers about the complications of the propeller flap. The partial necrosis rate in extremity reconstruction is more than 25%, and in systematic review, the partial necrosis was about 11.3%, and venous congestion was occurred in 8.1%. And this is meta-analysis comparing the free flap with the propeller flap, and there was significant higher complication rate on the propeller flaps. So it's quite difficult surgery. So this partial necrosis might occur in many occasions, but if those kind of necrosis occurs, it happens on the most important areas. The plates, bones are exposed on that area. So it's not an easy surgery. And most important thing, I think, in the propeller flap is to prevent those kind of the partial necrosis on the tip of the flap. So to minimize that partial necrosis of the tip or the tip of the propeller flap, there are 6 very important steps, and I mostly talk about 3 steps today. And first step is preoperative evaluation of the perforators. So we have to use, initially we use the handheld Doppler, but these days we use the color duplex. We can find a really good perforator with a good flow. You can measure the velocity of the perforator, size of the perforator, and we also can see the path of the perforator. We can find where the perforator penetrates the deep fascia, and we can also see the axis. In this picture, this is the point where it penetrates the deep fascia here, and it travels all the way on the defect layer, and it penetrates the superficial fascia here, and it goes all the way to the distal of the flap. So you can see this kind of axis, evaluate with the color duplex, and sometimes if it's possible, you can use the CT angio to identify those things. After evaluating the perforator, then in the OR, we identify the perforator by surgical dissection. Before we design the flap, we look for the perforators. So as you can see, we didn't make any additional incision after tumor excision. And this is the point where we mark the perforators the day before, and we find that perforator. The perforator should have good flow, and another thing is that the perforator should be near the defect. Maybe it should be inside the 3 centimeter of the margins. If there's a 5 centimeter defect and you find the perforator 1 centimeter from the margin, then distance from the perforator to the tip of the defect is 6 centimeter, right? So for the propeller flap, we can design 7 centimeter flap to cover those 5 centimeter defects. So 2 centimeter would be used for covering the defect. But if you find the perforator 3 centimeter from the margin of the defect, distance from the perforator to the tip of the defect is 8 centimeter, and you have to design the flap with 11 centimeter defect. And this area will be used to cover the defect, and this large area will be used to cover the donor site. So selecting the perforator near the defect is really good, really important. So it's closer, the better. And if there's a 2 perforator, one on the side of the defect and another at the tip of the defect, which one will be better. So for this defect, actually, if it's the perforator is on the side of the defect, it's quite difficult to close the whole flap with the one single flap. But if you find use the perforator near the tip of the defect, then you can rotate the skin and cover entire flap. So the finding the perforator near the tip of the defect is quite important. And three thing is really important. And when you find a really good perforator, when you see that perforator, shy surgeon, if they see that good perforator, find that good perforator, he smiles. And if Baobak find that perforator, he dances. And actually, JP Hong, he finds that good perforator, he come up on the chair and he dances. And what it means is that the most important thing is finding that good perforator. It's end of the surgery. If you find that good perforator, everything is done. If you design properly, if you elevate properly, it'll be 100% success. Those things you can control, but the perforator, that thing is that you cannot control the good perforator. If you find that perforator, every step after that is become really easy. So after that, you design the flap. You have to consider the axis of the perforator and skin laxity, and you have to consider the scar. So we found really good perforator here, and this is the point where it penetrates the deep fascia, and it travels this way on the fat layer. So we are trying to design the flap this way. So you find if there's a 5 centimeter defect, if you find the perforator here, we measure the distance from the perforator to the tip of the defect, and we mark the point with the same distance from the perforator to the defect. And after that, we design it and draw the flap with the width covering those defects. And we have to consider the donor side closure, and also we have to think about the tension on the flap margin. So donor side closure is here, not entire flap. Sometimes because this area, this portion will rotate it and close the donor side, some portion of the donor side. So we have to think about this area. And the tension of the flap is really important, because if you design small flap to cover the donor side primarily, and that small flap sometimes can cause the tension on the flap. So those tension on the flap might cause the ischemia on the propeller after the surgery. So designing with the correct width of the flap is really important, and actually it's quite difficult. How about the rotation angle? Is it better to have the 90-degree rotation, and 100-degree rotation is bad? But actually, I think the axis of the perforator path and the tissue laxity is more important. So if there's a tissue laxity this way and the perforator go this way, it's much better to design on the 90 degrees. But if the perforator, axiality of the perforator go this and the skin laxity there, then we can use the 180-degree propeller flap. And about the dissection of the perforator, if there's no scars, the 2 centimeter of the pedicle is enough for the 100 rotation. But there is a prerequisite that there should be no advancement of the pedicle, because in usual cases it's very easy to advance the flap to cover the defect, but there should be no advancement. There should be just rotation, and there should be no additional tension on the pedicle, and also there should be no scar. If there's a scar, just by rotating maybe 45 degrees, it causes the kinking of the pedicle. So you have to see, and you have to use the high magnification loupe to see and dissect the pedicle. You should, some doctor use 2.5 magnification, but I prefer to use 4 or 5 times loupe to dissect that pedicle. You have to see the pedicle by yourself. You have to see the artery and vein, and And after rotation, you have to see that the vein and the artery had a good pulsation and the flow by your loop. So some people always want to dissect all the way proximal to the source vessel to get the additional length of the pedicle. But for example, this is the defect and this is the propeller flap we are elevating, and this is the perforator here. So we are gonna rotate and cover the defect. But in case the perforator axis comes this way, if you dissect all the way to the proximal, you can advance the flap to cover the defect. But in most of the cases, it is directly coming from the deep muscle or coming from this way. Then even though you dissect all the way proximal, it does not help to advance the flap to the defect. So you have to see before the surgery, you have to evaluate this perforator path before the surgery to have additional advancement to the defect. So in those cases, if the perforator is going away from the defect, the additional dissection does not help that much to advance the flap to the defect. And another thing, are there limitations of the flap size? So if there's a 12 centimeter defect and you find perforator 3 centimeter from the margin, the distance from the perforator to the tip of the defect is 15 centimeter. So you have to design 18 centimeter of flap to cover those small defect, and 6 centimeter will cover or used for the covering the donor sign. I think elevating this flap is like elevating 30 centimeter size flap with one perforator. So if you elevate this kind of perforator, you have to worry about the marginal necrosis. You will prefer to use multiple perforators to elevate this large perforator onto flap. So it's not reasonable to recommended to elevate this kind of big flaps. So for the propeller flap, personally, if the perforator to the tip of the flap is, it should be larger than 15 centimeter, I will not use the propeller flap. The perforator to the tip of the flap should be less than 15 centimeter in most of the cases. There is an exception, but in most of the cases. And after that, you can elevate the flap and you can dissect the perforator. It's quite easy, but another difficult thing is the rotation and insetting. Sometimes you see the perforator, the propeller flap become ischemic after rotation. What should we do if you see that ischemia and less perfusion? You have to evaluate the tension on the pedicle and also on the flap margin. If there's a flat margin, excessive tension on the flap margin, they might cause the tension on the pedicle. So you have to see the pedicle after temporary suture with the staples. And if there is the less flow, then you can rotate the other way around. It can cause the less, it can maybe reduce the kinking of the pedicle, and there might be a better circulation on the flap. So you rotate the flap other way around is another option. And if there's too much tension on a certain border, you can open one border or flap and do the dressing, wet dressing, and send the patient to the recovery room. And you can close that margin bedside after 2 or 3 days. And even if you open one border, if there's a high tension on the pedicle, then you can do the delay. You can return the flap to the original position and suture it, and you cover the donor side with the negative pressure dress. You can do the dressing, negative pressure dressing on the defect, and you wait about a week, and then you can rotate again to cover the defect. It's another way you can minimize the ischemia after the initial rotation. So I will show some of the cases. This is the back defect. We found two perforators, one here and one there. So this perforator is locating at the tip of the defect because we're going to close this side, but the perforator was not that large, not that good. So we want to use this perforator as the pedicle of our propeller flap. So we close some part to make this perforator located on the tip of the defect, and axis of this perforator is going that way. It's better, and the skin laxity was enough on this area, so we designed this way, and we're gonna rotate about 45 degrees to 60 degrees to the defect. And this area will be used to close the donor side here. So it'll be used for the closing the donor side. So this is after rotation. So this, we use this flap to cover some part of the area on this margin. We close the donor side primarily. So there's no tension on the flap, and this is after the radiation therapy without any marginal necrosis or the descent. Defect on the thigh. So preoperatively, we measure the velocity of the perforator. This is 22 centimeter per sec, and this is 18 centimeter per sec. This one is better, but we figure out that this two perforator had a common source vessel. So if you dissect proximally, this perforator can be worked as a one perforator because it has a single pivot in the proximal. So we figure out, we decided to use this area because there is a skin redundancy on the lateral thigh. So we use these two perforators and rotate it, and you can see the two perforators having the one source vessels after dissection and rotation. You could close the donor side primarily, and this is after surgery. Quite similar, we find multiple perforators before the surgery, but this one is too far away, and this patient had a more skin redundancy on this area. So we decided to use this the perforator as a pedicle, and the size of the flap was 18 by 8 centimeter, and we rotated about 60 degrees to cover the defect. And without any complication, this is after radiation therapy, the donor side is quite good, and this is the flap here. Another knee defect, we found the perforator a day before the surgery, and this perforator is about 3 centimeter from the margin. So we have to elevate 20 by 6 centimeter of large propeller flap. So we rotated the flap, but unfortunately, the tip has a really fairly minimal flow. So we find another perforator on the tip of the defect, and we did one artery turbocharge to perfuse the distal area. So for now, if you have this kind of same defect, we'll use free flap to cover the defect. It's much simple because when you do the this kind of long perforator, the flap is quite large and the scar is even larger. So we're gonna, for it's doing the ALT flap or the skip flap will be another good choice for the coverage. Posterior thigh defect, distal posterior thigh. And the defect, from the defect, the perforator was about 4 centimeters. So we have to elevate about 19 by 8 centimeter. So we elevate the flap based on this good perforator, but quite similarly, the tip of the defect was not that good. So we have to use one artery, one vein supercharge on the tip. Using the perforator on the tip, we elevate the flap with another perforator here. So this is after surgery. As you can see, the flap is covering entire surface of the posterior thigh. So it's become quite large if you use that propeller. This is the last case. This is the back, had a cancer on the Majolin's also on the unsafe scar, bone scar. So the orthopedic doctor, the sarcoma orthopedic doctor, they excised the tumor, and additionally we excised some of the unstable scars on the lateral, both lateral end. So this was a defect. It's quite large defect, and we initially planned to do the ALT or DF flap to cover those defects, but on the CT angio, we found out that there was a really good perforator here, and the perforator was coming from this margin to the here. So when you use this perforator, if we dissect to the proximal, we can advance the flap to the defect. And another thing was that this perforator was going to lateral on the fat layer. So even if you elevate large flap, it will be well perfused because the vessel is all the way, you can trace it on the fat layer to the tip of the defect. So we designed the flap, we decided to use the propeller flap to cover those defects, and we make this triangle flap to cover this fish mouth incision here, and it should be 100% correct. There should be no error. So what we spent about 40 minutes, almost more than 30 minutes to design this flap, and we made an incision to see this perforator and size of the perforator and precision. We actually see it, because even if we cannot use this perforator as a propeller flap, the pedicle of the propeller flap, we're going to use that as a free flap recipient vessel. So we dissected and identified the perforator, and we designed the flap. After that, we elevated and we rotated the flap, and it was fit into that defect, and there was no tension on the pedicle. So this is after surgery. There was no marginal necrosis or the descent of the flap. So conclusions, the perforator pedicle, the propeller flap is, we can cover the defect with light tissues, and it has a steep learning curve, but with the proper planning, choosing the good perforator with good access, and design the flap, plan the propeller flap for the medium-sized defect, it would be a really good option for the soft tissue reconstruction. So thank you very much for listening. And we used to do the lower extremity workshop every year, but unfortunately we couldn't do it this year. So we're gonna plan it next year. We hope we can do it next year. And we have the live surgery for 2 days, and we do the cadaver workshop hands-on. So you just don't see it. You elevate all the flap by yourself. So it's really good course, and we're always welcome to come. And thank you very much. Thank you.
Thank you, Peter. Fantastic talk. And I think for those of us who either haven't done a propeller flap or haven't done too many of them, I think it's really nice to see your step-by-step instructions of how to do it, and also the details of the measurements as far as how to make sure you design it properly so that you don't do all that work and are still deficient in the amount of flap. A couple of questions that I had before we open up to the audience. You mentioned that sometimes if the flap, once you elevate it, isn't looking good, you would delay the flap, and that makes sense. That's true with pedicle flaps as well. How often in your experience are you having to delay your propeller flaps? Like roughly what percentage of time?
So in the initial phase of our practice, we did it maybe once in 5 times like that. But these days we don't do it. We do more. We take time for the design, and we do more dissection on the proximal. So if we do it if there's something wrong in the design and dissection. So
Mhm.
it's a backup plan for doing those delaying.
Right.
So if you design properly, if you design enough large flap to cover the defect, we don't face it. But in the case with the trauma, and the case with the pressure sore, it sometimes happen.
Mhm. Got it.
But in the fresh tissue, you don't have to worry about those things. But in the scar tissues, sometimes it happens.
Got it. And then speaking of traumas, it leads me to my next question. Our practice is primarily trauma-based. We don't do as much cancer reconstruction. So in a traumatic case where you're unsure about the zone of injury, do you feel that propeller flaps are still as viable of an option? Is there anything else you would do potentially with the imaging that you do with ultrasound to try to see if you're in the zone of injury still, or do you worry about it more in traumas?
So if you plan for the coverage of the trauma cases, many of the cases you consider free flap, right?
Right.
So
Yep.
for the free flap elevation, you have to look for the recipient vessels. So with the preoperative evaluation, it's quite difficult to see that those postoperative change of the recipient vessel. But if there's a flow on that, maybe image color handheld Doppler or the color duplex, then operatively you dissect the pedicle from the margin of the defect.
Hmm.
And if that perforator is really good for the rotation, if arc is okay and the pedicle above the deep fascia is okay, then you can try to do the propeller flap. But if you see that perforator and there's an injury above that deep fascia, then you
Hmm.
can change to the free flap. So it can be the initial option for the coverage. But if you see that perforator by your eyes under the loop, if it's
Hmm.
not that good, you can just change it to the free flap in the trauma cases.
Got it. Now, speaking of the duplex, what frequency ultrasound are you using? And can you comment on the flow velocities that you're happy with these perforators?
So we are using the regular one. So usually we have 8 megahertz, and we usually use the 15 megahertz
Mhm.
probe, and we are happy if the flow is faster than 20 um, centimeter per sec, and in if it's really good, it's above 30.
Got it.
So, but if it's around 20, we can use it. If it's around 20, we dissect the perforator and see the pulsation.
Got it. So
So
20 is the threshold, basically. If it's below that, you
yes,
would
yes,
consider doing something else.
yeah. But around 20, but less than 15, we never use it. But maybe around 20, we're gonna dissect the pedicle, the perforator, and see whether we can use as a recipient vessel for the propeller flap.
Got it. And is 20 also your threshold for using the perforators as recipient vessels for a free flap? Is it the same number that you're looking for?
Yes, yes. If it's 20 before the surgery on during the preoperative evaluation, we think it's quite safe. But even if it's 20, we will not just use it. We just open the vessels if it's perfect. In most of the cases, it's perforators.
Yeah.
And in perforator, if it's 20, we cut the perforator and maybe open the end vessel of that small branches, and there should be really good pulsatile flow.
Hmm.
But in some of the cases, even it's 20, if it does not have that projectile precision pressure coming out from that vessel, we will not use it. But for the screening of the selecting the vessels, 20 is really good
Got
number.
it. Another question that I had was, you mentioned the directionality of the rotation, whether you rotate clockwise or counterclockwise. And I remember a paper that I think you and JP published recently on that. And so do you do any intraoperative monitoring of the perforator with ultrasound when you rotate 180 versus, or clockwise versus counterclockwise to see which direction you want to go?
Uh, y- Usually, we did it for the study, but usually we don't do it
Okay,
routinely.
got it.
We prefer to see the perforator by under the loop and
Okay.
see the margin bleeding
Hmm.
at the fat layer. That's more important, we think. And we hear the sounds with the handheld Doppler. If the sound decrease, or we can hear that compression of the vessel, high peak sound
Hmm.
with the decreased intensity, then it's not that good. It means that there's a kinking of the
Yep.
pedicle. So we more focus on the basic things, bleeding from the margin, and because using the color duplex, it also has the errors. So we're gonna
Right.
depend on the simple things to see which side, which rotation angle direction is better.
Hmm. Now, speaking of kinking of the vessels, have you noticed a correlation on between the length of your perforators and the potential venous congestion? My thought is if you have very long distance between the skin and the parent vessels and you rotate 180, you're essentially distributing that spiral across a longer distance versus a very short distance. Does the distance between the skin and the parent vessels affect your decision to do a propeller flap? And if so, how?
Uh, yes, it might affect the venous maybe kinking of the vessels, but if there's no scar tissues
Hmm.
for the regular size perforators, I think 2 centimeter is enough for that simple rotation, 180 degrees rotation. But if there's a scar, it can compress the veins. But usual cases, 2 centimeters is enough. But
Okay.
I saw some of the cases. My juniors were doing the surgery, and um, they dissect about 4 centimeters on the pressure sore patients, and they rotated, and it was totally obstructed because it had a scar tissues on that
Mhm.
area. And when you rotate it, the rotation was not evenly distributed. So when there's a scar, it does not
Right.
rotate that much. So it's just like elevating the
Yeah.
rotation with really maybe 5 millimeter of pedicle. So you have to see it. It's not, you cannot apply that same concept for everyone, every
Right.
case.
That makes a lot of sense. So if you obviously have a specific area of scar, that instead of having this gentle spiral, that you would have actually a kink at one particular site. So thanks for that. We have a couple of questions from our good friend Betty Kushida from Mexico. You may know her. She has a question. The first question is, have you performed any intraoperative perfusion tests such as ICG after propeller elevation? I'll ask this one first, and I'll ask you the second one.
Yes, we do it. We can check it. If some of the flaps, if the perforator itself is really large, uh, it's quite easy to monitor. If it's
Mhm.
kinked, the bleeding decrease a lot. But in some of the perforator, the propeller flap, the perforator is really tiny. Even with just elevating the flap, the marginal bleeding is not that good, sufficient. So for those kind of flap, if for monitoring, the ICG is really good method to see the perfusion on the surface. So if you
Great.
are not confident with usual manners, you can use the ICG.
Got it. Well, that's a great question. Thanks, Betty. Her second question is, how did you establish the ultimate propeller flap size as less than 15 centimeters without any vascular help or augmentation?
And so the as I showed on the last case, the axis of the perforator is really important. So if you design the flap along that axis, you can design really large flap without any hypoperfusion. But if it does not have that axial pattern type, the distance should be less than, I personally should be less than 12 centimeter
Hmm.
is the maximum. And actually we are now doing the study of the partial necrosis of the free flap, and that uh, the if the tip of the defect is far away from about 10 centimeters from the perforator, the partial necrosis rate dramatically increases. So we're gonna
Hmm.
publish this paper this year, trying to do it. So the if the does not have that axiality, we can check the axiality with the color duplex or the handheld Doppler or the CT angio. If we cannot find that axially vessels, the perforator should, the flap should be less than 12 centimeter size.
Got it.
Mm.
Great. And then we have another question that was just posted, that you mentioned that 2 centimeters of dissection typically is kind of what you need. The question is, do you think dissecting past the fascia has any positive effect on congestion or arterial flow? You implied that you do dissect past the fascia, right?
Yeah, it depends on the flaps, but usually we just open that fascia
Hmm.
because the D fascia, where there's a D fascia and the fat, we're gonna rotate just above the D fascia. So 2 centimeter means that we go under the D fascia.
Okay,
So we do intramuscular dissections,
right.
and there's a tip, but we just not only open the fascia, sometimes we cut out the D fascia for the
Yep,
to minimize the compression of that the pedicle with the fascia. Sometimes when you just make a slit, it can compress when we do the muscle contractions. So we cut out some portion of the D fascia to minimize that compression.
got it. Great. Well, Peter, thank you so much for this very interesting talk. I personally haven't done any propeller flaps, I have to admit. So I am now very curious to actually try a couple and see how they go. But I feel like you have given us the tools that we need to at least start doing them in a safer way as possible. So thank you so much for that, and thank you for answering all the questions that we had. I also want to thank everyone for joining us today, and I want to just mention that tomorrow morning at 7 a.m. our time, we do have Professor Andres Rodriguez from Sweden talking about endoscopic insetting of free flaps for skull-based reconstruction. Peter, thanks again. It was great seeing you. Not as good as seeing you in person, but hopefully soon we'll be able to see you in person as well.
Thank you. Thank you so
Great.
much.
Have a great day, and say hi to everybody at Asan, okay?
Have a good evening.
Alrighty. Take care.
Bye-bye.
Bye-bye.